The second type of strabismus is the manifest strabismus or the heterotropia, which could be comitant or incomitant. Manifest strabismus or heterotropia. It's an evident deviation of one eye. The patient comes into the clinic with the appearance of squint, and it's a true squint. As seen in this child, the right eye is deviated inwards and the left eye is straight. So this is a true manifest esotropia. The first type of manifest heterotropia is comitant strabismus. Comitant strabismus is abnormal deviation of one eye, and this is the definition of any strabismus, with equal angle of deviation in all directions of gaze and normal ocular motility, and this is the definition of comitant. So if we measure the angle of deviation in the primary position, it's, for example, 40 prism diopters. On right gaze, it's 40. On left gaze, it's still 40. So the angle of deviation is equal in all directions of gaze. And if we test for reductions and inversions, there is no limitation of movement in any direction. There is normal ocular motility. So it's an abnormal deviation of one eye with equal angle of deviation in all directions of gaze and normal ocular motility. As seen in this picture, this child has right esotropia, but there's no limitation of movement in any direction of gaze. So this is comitant esotropia. Types of comitant strabismus: it could be convergent or esotropia, divergent or exotropia, or vertical, which is hypertropia. The etiology of comitant strabismus. Comitant strabismus could be congenital, which starts at birth or during the first 6 months of life, and usually it is esotropia. Second cause is errors of refraction, uncorrected errors of refraction, just the same as heterophoria. Hypermetropia causes esotropia, as there is too much accommodation, too much convergence. The patient first develops esophoria and then it becomes esotropia. Myopes, they do not accommodate because they focus the object at their far point. So no accommodation, no convergence. Myopes first develop exophoria and then it turns into exotropia. So hypermetropia causes esotropia and myopia causes exotropia. The third cause is an organic cause of the eye or sensory strabismus. For example, opacity of the cornea or the lens, disease of the macula like a macular scar due to trauma or toxoplasma or toxocara, or a dangerous disease of the macula, which is a retinoblastoma. If the retinoblastoma affects the macula, the patient does not see and can present with strabismus. This boy, he has right cataract, causing exodeviation of the right eye. And this baby has a retinoblastoma, causing an esodeviation of the right eye. And the fourth cause of comitant strabismus is amblyopia. Amblyopia, there is poor vision in one eye, so the brain does not maintain muscle balance on this eye anymore, and the eye starts to squint. So amblyopia causes strabismus, and strabismus can be a cause of amblyopia too if unilateral. Or if there are no cause detected, it's just idiopathic for no reason. The patient developed the strabismus with no apparent cause. So to summarize, causes of comitant strabismus are congenital, uncorrected errors of refraction, an organic cause of the eye, amblyopia, or idiopathic. Symptoms: the patient complains of the cosmetic appearance of ocular deviation, or the patient can complain of diplopia. In small children, diplopia occurs just at the very start of strabismus, at the very onset of strabismus, but after a short time actually, the brain suppresses the image of the squinting eye and the patient develops suppression and no more diplopia. He sees just one image by the straight eye. But if strabismus develops after the age of visual maturation, which is between 7 and 10 years of age, the patient develops diplopia and it could be persistent. It does not disappear because the patient cannot suppress the diplopic image anymore. So symptoms of comitant strabismus are cosmetic appearance of ocular deviation or diplopia. Treatment of comitant strabismus. If there's an error of refraction, we need to correct it by giving the patient the proper glasses. If there's amblyopia, we do occlusion of the sound eye to improve vision in the amblyopic eye. And if after giving glasses and occlusion, still there is persistent strabismus, surgery is indicated. This girl has a fully accommodative esotropia, which is fully corrected by glasses. So treatment is just glasses and no surgery is indicated. On the other hand, in this girl, glasses partially corrected her esotropia, so she needs glasses and surgery. This is patching of the sound eye for treatment of amblyopia. What surgery to be performed? Either we weaken a muscle or we strengthen a muscle. The first type of surgery is weakening a muscle, which is by recession, where we move the insertion of the muscle posteriorly, so the distance between the insertion, the new insertion, and the origin becomes shorter. So the muscle becomes slackened, not tight, and this weakens the muscle. Or we strengthen a muscle by resection, where we cut part of the muscle and then we suture the muscle back at its anatomical insertion. So now a shorter muscle is crossing the same distance between the anatomical insertion and the origin. And this short muscle will be stretched or very tight. And this tightness will strengthen the muscle. Surgery for esotropia. The classic treatment for unilateral comitant esotropia is medial rectus recession plus lateral rectus resection. And for alternating esotropia is bimedial recession or recession of both medial recti. This is the classic treatment, but still according to the surgeon's preference, unilateral strabismus can still be treated by bilateral surgery and bilateral strabismus can be treated by unilateral surgery. Surgery for exotropia. For unilateral exotropia, the classic treatment is unilateral lateral rectus recession and medial rectus resection. So we weaken the overacting lateral rectus muscle and we strengthen the medial rectus muscle to pull the eye inwards and straighten the eye. For alternating exotropia, the classic treatment is bilateral lateral rectus recession, where we weaken the lateral rectus in each eye to straighten the eyes. So treatment of comitant strabismus is first by glasses and occlusion if there is amblyopia, and if these fail, surgery is indicated. The last type of strabismus is the incomitant strabismus or the non-concomitant strabismus, which could be due to muscle paralysis or paralytic or muscle restriction or restrictive strabismus.